Hey guys, going to shoot another video here. Going to be looking at doing a tracheostomy change. Let me move this so you can see a little bit better. Okay, bunch of different reasons why you could end up needing to change a tracheostomy tube. Some of them routine, some of them emergent. The emergent ones, a couple of little modifications were obviously going a little bit quicker and stuff like that. It's mucus plugging, stuff along those lines here. For our particular purpose, we're going to be switching Frank here. He has a 7.0 uncuffed Bavona. We're going to be switching over to a cuffed, whether that's to provide another degree of airway protection or be able to deliver positive pressure ventilation. We won't go down that avenue here. Okay. So the main things we're going to be wanting to do, we're going to need to ensure that we got all the essential stuff that all your trach patients should really have. And that starts with making sure you got suction, checking the pressure, making sure it's set up and ready for use here. And then main resuscitator mask should be around in case something else bad happens to their trach or you can't get it back in. Right now, I'm going to go ahead and I'm going to start pre-oxygenating this gentleman here just with his trach collar. So I'm going to bump up his FiO2 on his venturi back here, crank up the flow, input flow to make sure he's getting enough total flow. While I'm kind of getting some stuff done, I'm going to go ahead. I'd start with a little assessment here, making sure I got a good baseline, listening to breath sounds. I would recommend going down and suctioning this patient at this point. They're going to cough a lot of stuff up a lot of times, and it makes it a little bit less messy. We'll kind of skip that step for time's sake purposes. You're going to want a second set of ties. Okay, we're not going to reuse any of this stuff. And likewise, a drain sponge, everything along those lines. You want to make sure you have your tracheostomy tube. Okay, so once again, we're going to be switching over to a cuffed Bavona TTS. Okay, so no intercannula, siliconized trach. Take sterile water in the cuff here. All right, so you want to go ahead and you know what we're switching to ahead of time, whether it's from hopping in or talking to a doctor or something like that. I'm going to go ahead and I'm going to get a syringe filled with sterile water. Okay, and I'm going to hook that up on my pilot balloon, pull back and ready to go. In real life, I'd probably have 10 mils of sterile water in there. We don't know how much it's going to take. And we'd be using minimal occlusion volume to assess how much sterile water to put in there. I don't wear sterile gloves when I'm actually touching the tracheostomy tube or anything like that. I just try not to touch on the outer cannula or anything. It's okay to manipulate the flange. If you wanted to try and do so with sterile gloves, that's totally fine. It's not essential. Just try not to touch the parts that go into the patient. I usually like some sort of a sterile base, and whether this is from a trach care kit, I use the package that the tracheostomy tube comes in sometimes. I'll use the sterile packages of suction as my sterile field, stuff like that. Okay. I go ahead and I'm going to leave that trach out. All right. Just general disclaimer, I do not have the appropriate obturator or the kind of insertion facilitating device for the Bavona TTS. Usually it's got two clips and there's two little grooves, one on the top, one on the bottom of this patient connector. The obturator actually clicks in, and then to take it out, you got to do a twist and kind of pull back out. This one suffices, but it's not the real deal. So make sure you pay attention to that clinically. I'm going to go ahead and I'm going to get my tracheostomy tube kind of ready. I'm going to put my obturator in. You can see it kind of sticks out through the end just a little bit, gives it a little bit more rigidity. You really can't get a Bavona in somebody without an obturator. All right. So I'm going to go ahead and I put a little bit of lubricant on my sterile field here. I use just regular gel lube, not PAM here, but we'll go ahead and we'll go that route. Want to get a lot of lubricant on there, otherwise this can be a little bit tough. The other thing I do, I get a new set of trach ties. I do get them hooked up on one side. I keep the adjustment, extra little piece of Velcro on my side for easier adjustments and manipulations. I'm going to run that through the back of this flange here, kind of get it all good to go. Okay. So I do have open suction for afterwards. Sometimes you might want to check CO2 after a trach change. I don't typically do it. If I get a good strong cough, when I go down and suction afterwards, I feel pretty comfortable with that. Typically, if I can get good chest rise as well and everything like that. On the ventilator, you'll know if you get returned exhale and inspired tidal volume match up and everything like that. But I still go down and make sure I can get a good cough. With a suction catheter, the things we're worried about being in a false pocket, so like a weird abnormal dilation or something in the trachea where you're up against tissue and not really able to get that thing to come, the catheter to come out through, high resistance for ventilation through it, or being in the subcu, so not actually in the trachea, but thinking you are by going through the stoma. Okay, so you got to make sure. I typically do breath sounds, make sure we're good, and then pass the suction catheter. Use CO2 if you really wanted to. Okay. we're going to want to go ahead and lay this guy back. All right. It's not going to necessarily make it easier for the trach to go in, but it's going to make it easier for us to access that stoma site. I usually roll up a towel or a pillow and put it behind the shoulder blades. And that kind of helps them get like this so we can easily access this stoma. This should not be done if it was if this trach is less than 7 days old. Those stomas aren't mature enough, and if we pull it out, we might not get it back in. Okay, and that would probably still be sutured in as well. So I'm going to go ahead. I'm going to drop old Frank down here. I'm also going to raise the bed up a little bit. Might have to pull him some so you guys can see a little better. Don't be hunched over, so raise up the bed, make life easier on you. Okay, I got him hyperoxygenating. Everything's all good. Got my supplies. So Frank would be stiff if I roll up a towel or a pillow behind him, but we'll go ahead. I'll show you what I mean here. And that just allows that neck to kind of be more open and me to allow to get into everything. Okay. So one thing I like to do, I go ahead and I pull that old drain sponge out. I do my same trick from Trach Care. I put a little loop in this thing to help me kind of pull the old ties through. Okay, so at this point he's been hyperoxygenated. I leave the trach collar on him for the most part, but I'm going to go ahead and kind of pull it down and out of my way. I got my loop here, and all I'm going to do, right, trying to be careful not to touch my trach on anything. Go ahead, and I'm going to try. So I'm disconnected here right now, all right, from the trach ties. You notice I'm putting pressure on my flange of my trach so it doesn't come sliding out. I'm going to go ahead and I'm going to try and pull my new ties through. Okay, that way I'm not reaching back behind. So I'm all good. I got it back behind the neck for the most part. At this point, if this tracheostomy tube was a cuffed one, we'd be deflating it. He's got an uncuffed and we're swapping for a cuffed. Okay, so what I have him do is take a big deep breath in, big cough out, spit that out. I'm going to quickly go back in and I'm pulling the normal curvature. Okay, I'm trying to make sure I'm dropping down into the trachea. So you're going to push, pop that thing in. As soon as we're in, I'm pulling out the obturator. Okay, with that obturator and they can't breathe, I would go ahead and before I even secure, just like an ET tube, I'm confirming I'm in the right spot. So I'm going to inflate the cuff. Typically when you're putting these in, they'll cough a little bit. You could hook up to an ambu bag and make sure you got good chest rise. I probably don't have enough water in this cup to see those guys' strange airway here. Make sure you got good chest rise. Okay, typically cough a big amount of secretions out and everything. If you got good chest rise, you're probably okay, all right, with manual ventilation and everything like that. But if you had a patient where you're really, really not sure, you can still go ahead. You could check CO2. I'm going to just go ahead and get him hooked up, and then I'm going to pass the suction catheter down and through to make sure he's okay. I'm breaking my rule of thumb here about not looking down a trach. Nice and secure, but I put my drain sponge in still. Okay, I'm going to go ahead, go down with a sterile set of gloves. Some people save the obturator. I'll typically put it back in my sterile field and put it in a bag. But honestly, I'll be using a spare trach. If he pulls his bone out and it falls out on the tissue, I'm not putting it back on him anyways. So I'm not big on saving the obturator and like taping it to the head of the bed typically or anything like that. But you'll see people that kind of do that stuff. So both my gloves are still sterile at this point. I'll go ahead and I'm going to pull this out. And all this does is make sure I can pass that thing down and through. I might have got chest rise, but it could have required a lot of ventilating pressure. I want to make sure I can pass that suction catheter down and through that patient's tracheostomy tube. So a nice big deep breath. All right, go down, make sure it seems like you can pass it through, lay on. You should get a good cough and suction, pull it back out. All right, go ahead and get rid of these nasty suction gloves. I put on another set of gloves here. And same deal. You can listen to breath sounds. You could do this again with manual ventilation if you're really concerned. Make sure you got good aeration. Everything looks good. We're going to go ahead. We're going to get them bumped back up here. All right. You can slip that pillow back and out. Make sure we have an appropriate replacement trach. It should be the same size and cuffed, okay, in case something happens to this one. And then, like I said, whatever you want to do with the obturator. Stop for this guy here. Raise him or lower him back down. I'm going to go ahead and I'm going to return him to whatever previous oxygen therapy he was on before. Okay, make sure everything's all good. Let's talk a little bit about the different variants if you're using a Shiley tracheostomy tube. So the Bavona, once again, no intercannula or anything like that. If we had a Shiley, let me come around and push this back here. if we had a Shiley tracheostomy tube with that removable inner cannula, you notice the obturator is a little bit different. It doesn't fit with that in there. Okay, so what we end up having to do is take that inner cannula out, but keep it handy. Put it in your sterile field or whatever. The obturator goes in. Okay, slide that thing in. Pull the obturator, but you can see we can't hook an ambu bag up with that without that 15 millimeter connector that's attached to that inner cannula. So you'd have to like that. Okay, so that's the biggest difference, and this is something that's going to make more sense to kind of play around in class. There is no formal checkoff for this. This is just something, give you a little introduction to. The first time I had to do it was on a patient. I would have much rather than walk through and done it on a mannequin, but I didn't have that luxury. So you guys at least will be able to do that. And that's about it for the trach change. Okay. Once again, it's a little bit different if it's high stakes and emergent, and we'll kind of cover emergent and airway troubleshooting here a little bit later in the course. All right. Thank you.